Hey, everybody, welcome back to the Overrun podcast. My name is Ed Bowder.
I'm Dan Schwester.
And coming back on the podcast today, Dr. Peter Antevy from Florida. Dr. Antevy, how are we doing today?
Hey, guys. Great to be here.
Doing good. Great to have you back. We're always happy to talk to you.
Absolutely.
You, sir, have been a busy bee. There's a lot of stuff that Dr. Antevy is doing right now. There's a lot of work and data and research that's coming out of Florida, and that's all stuff that we love. Today, Dr. Antevy, I want to talk to you specifically about sepsis and how it affects, or how EMS is affected by it. Because for a long time, I feel like there was kind of a question of whether EMS should be involved in sepsis at all. And we do want to get into kind of a bigger picture of sepsis is a hospital problem. Why should EMS deal with it? Why should we do that in the field? Why start treating patients earlier? Why do any of that? So let's start out from the top. Let's kind of break down the myth of the emergency department. We're 2 minutes away, whatever. Let's get into that. And Danny, I know you wanted to talk about that a little bit too. So Dr. Antevy, let's hear your thoughts on that, and then we'll take it from there.
Yeah. So I think that, now that I've been in EMS for 15 years, it's very interesting that there are certain things that we do that as soon as we get to the hospital, things start to have to happen quickly, and they put some time parameters on those things. So let's start with something that's not sepsis. But let's just take, for example, traumatic hemorrhage. We were bringing these patients who were dying into the hospital, and suddenly, when we got through the magic doors and the doors opened up, we walked through them, someone brought the magic substance called blood, because that was a life-saving thing. And we said, well, if the life-saving thing is blood, well, why aren't we just doing it in the field? And that spun people sideways, right? but in reality, that's the truth. And I'm going to end it with, I'll tell you why all this is happening, but let's go to sepsis. Magically, you bring this patient who's dying from a bacterial infection, the tachycardic, the hypotensive, they look like crap, and you come in, and then all of a sudden you have to rush to get fluids and pressors and antibiotics. What? So wait, why can't we do those things? And there's other things as well, right? I think we've all figured out that cardiac arrest is an EMS thing. But we still have a lot of agencies, guys, who are rushing the death patient to the hospital, all for the doctor to say time of death is, 1:23 p.m. Right. So here's my overall thought process of why this is happening. There's two parts of the equation. Number one is we have pre-hospital clinicians who don't feel that what they do matters, right? And therefore, some doctor told me I have to bring the patients in because that's where the patient needs to be. And that's a bunch of bogus, right? And then on the other hand, there's a bunch of doctors who don't understand or value EMS at all. They think we're a bunch of ambulance drivers. So those two things have to change, but the chicken or the egg, it has to start with us. We have to show them that we are of value. We are value to the patient. We have great training. We have great protocols. We can carry blood. We can carry antibiotics. We can do finger thoracostomy. We can do ultrasound. We can do plasma. We can do all the things that you thought were only regarded and reserved for you in the emergency department. We can do in our own emergency department, which is in the field. That's what has to change. And unfortunately, that message hasn't come out so strongly, and we're going to be pushing it out this year, next year, and for many years to come.
Some of that dangerous progressive thinking we like to hear about.
Yeah, I love this because, I think as a clinician, as a paramedic, it's energizing, it's empowering. I remember a time when, all we could do is drive fast, and, there was very limited scope of practice. But if you go back and you think, hey, 50 years ago, only physicians defibrillated, only physicians intubated. And then they decided that this stuff needed to be applied at the point of illness or injury to actually make an optimal impact. And I think that's what I really liked about hearing this. Like, you had a discussion with Rob Lawrence on EMS1, and there were some things that you felt that all EMS agencies need to be doing and adopting. And I think this could be rejuvenating for the industry too. Now we're going to have people empowered to do this stuff. And it's also going to take the burden off of the emergency department, which we know people are not going there any less. There's tons of things going on. There's an inertia when you hit the hospital doors. We can be a force multiplier. So what's I know you feel that way, but how would you frame this to the people that are like, hey, we're just 2 minutes from the hospital, or I'll just drive. We'll just drive fast and get them there. Or I don't want to stay and play. We're supposed to move. We hear a lot of times our medic units in New Jersey, we call them mobile intensive care units. And a lot of times people would say, well, the M is for mobile, meaning drive. And we would try to say, no, we're bringing the emergency department to the patient.
We come to you.
Yeah,
Right.
that's the mobile.
Yeah. There's a lot to unpack there. And I think where I would start with somebody who asked me those questions, I would say, number one thing is I want to know before we even have this conversation is show me your data, right? So imagine I came to someone and I said, hey, you need to do high performance CPR. And they said, well, we do high performance CPR. Well, the next thing is show me the numbers, right? Show me the receipts. And if you show me that your neuro intact survival is 2%, when I have an agency that's at 14%, then there's a problem there. If you show me that your septic patients that you've transported into the hospital in the last 12 months, which by the way, we all have lots of them, there aren't that few, there are a lot of them, and you follow those patients up and you have a 40% mortality, then you have a problem, right? So I always think you have to start with what are we doing today? Now, the second piece of that is that I like how you said it. You're very politically correct. We're going to reduce the burden of the hospital. Okay, I'm going to say it a little differently. The hospital is only doing what they're doing because they have to get paid. CMS, Center of Medicare and Medicaid Services, says, you want to get paid for this septic patient? You have to do these things, the SEP 1 bundle, within a certain amount of time if you want to get paid. So now we come along, and Danny, you're right. They should say, wait a minute, you're going to do that for us? Yes, right? Because now we can get paid. That's all they care about. So the hurdles we had to go over were, they said, it turns out that we have to figure out how to get credit for your fluids. We have to figure out how to get credit for your antibiotics. Because if we can't get credit and we didn't do it, then the federal government thinks we didn't do it. We don't get paid for it. So once we figured that out, and now they say, as long as there's a start time and a stop time to the fluids, they can get credit for it. They figured out a way to document our antibiotics, even though it wasn't put into their Epic system or Cerner system. They figured out a way to get credit for it. All of a sudden, they become very happy. And this whole theory of, oh, well, we don't have blood cultures, that's all nonsense. They don't care about any of that stuff. They just care about, do I check the CMS boxes so I get paid? And so once people start to understand what the hospital really cares about, and you can fix those, then sepsis belongs in EMS first, just like trauma and hemorrhage belong in EMS first, just like TBI belongs in EMS first, just like cardiac arrest belongs in EMS first. There's only there's probably like 10 things that we could talk about that are EMS first things, that if healthcare realized what EMS can do, they would say, my brothers and sisters in EMS, we ask you to do the right thing for us, and we'll just take the baton. And so we haven't published this yet, but this is some early data, so don't quote me on this, anybody. But our early mortality rate is only 8%, with a cohort of patients, if you guys read the paper that we published, that half of them were in shock. These are some sick people, right? So once we prove that, and there's another study which we can talk about coming out of Canada that's going to prove this as well, all of a sudden it's going to be very clear really fast within the next 12 months that sepsis care needs to start in EMS, period, end of story. It's so obvious.
And we're going to dive into this paper that came out about a month ago in pre-hospital emergency care. But something that I think is interesting that you mentioned, because we have to, we get into the business of medicine, right? Where I think a lot of times we have conversations, what can field staff do to try and improve the likelihood of this intervention or whatever? I think it's important to come from the point of view of, the check writers, right? Where in a system like yours, and I don't want to delve too much into, the municipal disagreements and whatever that you guys had, but there's systems like ours in New Jersey where the medics are hospital based. So it occurs to me that in a system like this, if your responding unit is based out of a hospital, and a lot of times the BLS is also based out of the hospital. So if everything is involved in this one tight little system, you're going from, Steve's EMS to Steve's paramedics to Steve's hospital. It seems like you can probably include all that in one bundle because it all gets sent in one bill as is.
Right.
certainly, certainly we're not going to write that legislature or policy today, but it feels like with policies like that, whenever I hear the objection is like, oh, well, the hospital, can't do it. And it's kind of like, well, I mean, we're owned by the hospital. So,
Yes.
and it occurs to me like, well, if there's municipal agencies that can get out and interface with however many hospitals they're working with, it seems like other organizations could work that way. And, in conversations that certainly that you and I have had, or that we've all had, frankly, off air, and in the interview you did with Rob Lawrence, that was in 2023, talking about sepsis coming out to EMS. And, we spend a decade talking about something coming out into the field, and then it finally does. And it's, what's the argument? It was like, first it's against nature, it's against, God or whatever. And then we knew it all along, where it's that kind of, we have that kind of interaction with a lot of these things where, so what's your frontline treatment for sepsis? Fluid, pressors, antibiotics. And I remember, I mean, a year ago, maybe, but even like, 4 or 5 years ago, like, well, how are you going to differentiate between a gram negative and gram positive bacteria? Like, I'm not,
Who
but
cares? That's what I say. Who
but
cares?
if someone's in a communal living environment and they have a fever and they're altered, I don't, it doesn't matter what the gram stain looks like. You know what I mean? That conversation was always very frustrating to me, because it's like, well, it doesn't really matter. Like, as long as we're not giving them penicillin and they're allergic to penicillin,
Right.
it seems like we can stop them if they're the wrong broad spectrum antibiotics.
Right. So I agree with everything you said, and I'll start with the New Jersey hospital thing. You guys should be the first people to be doing. I agree with you. I mean,
You heard it here first. We
Right.
should be the first.
Yes.
Go Jersey, go.
Right. You are connected to the hospital. It's basically a continuum of care. It just makes sense. You're an extension of that emergency department. Okay, so that's number one. As far as what we've done here and what could be done into the future, as far as these, I guess we'll talk about the blood culture real quick thing. If you have 40% of people dying, and by the way, those people who die, who got cultures in the hospital, those cultures came back after they died. Okay.
Right. Yeah.
So why not just give them a broad spectrum antibiotic and cover what the potential causes could be, right? And only have an absolute reduction of 12% of cultures by giving the antibiotic. What do I mean by that? It means that if you have two cohorts of patients, one waited for cultures first in the ER and one didn't, one got antibiotics in EMS, you only have an absolute reduction of 12% of those cultures being positive. That's nothing, right?
Yeah.
So, and also many of the cultures that come back positive, a lot of them are contaminants, and many people don't grow anything. So when sepsis is such a big killer, much bigger killer than cardiac arrest by far, right? If you look at your cardiac arrest numbers and you look at your sepsis numbers, at whoever's listening, at each of your agencies, the sepsis numbers by far outweigh the cardiac arrest numbers. What people don't see is that those septic patients end up in the hospital. They look alive, right? They look pretty crappy, but a lot of them are dying the next day, 2 days later, 3, 4 days later in the ICU because they're septic, right? So let's look at the numbers, and what the doctors will tell you. If I don't get a culture and I put someone on these big boom antibiotics, right, cefepime, Vanc, the whole thing, and I don't get a positive culture, well, now I have to treat that patient for the full course, right, full 10 days. Whereas if I would have gotten a culture and I would have isolated the bacteria, now I can specify the not broad spectrum, but the more narrow spectrum antibiotic, and now I can keep them in the hospital for 7 days. I'm just kind of giving you the number. So there's a little arbitrage there of 3 days. Their theory is I need a culture so I can save the patient 3 additional hospitalization days. What I'm saying is you're going to save maybe not all 40% of those people dying, but maybe you're going to go from a 40% death rate to a 10% death rate. Multiply that times 100 people per year. That's a lot of people.
Right.
That's a lot of people. And who cares about the extra 3 days that you're causing them in the hospital, if that's even true, right?
And dead people
Well,
don't pay bills anyway.
Yeah.
Correct.
Well, and even getting back to the business part of it, these are people like, if you have improved scores, you're going to have improved reimbursement, which means you're going to, you have more money to the hospital, which can improve salary. Like it's all of this. It almost feels like a butterfly effect kind of thing.
It's a cascade.
Right? Where Right. But I feel like you can explain like, hey, we can treat sepsis in the field. Like this can be done. And if we do that after 5 years, you know, that can buy new ambulances or whatever else. And it feels like as an industry, we're very difficult in extrapolating those kind of
Yeah,
things.
we are. Well, I'll give you another perfect example. I love that analogy, the whole blood thing. It turns out when you give whole blood in the field, you save a life, and therefore the hospital makes hundreds and hundreds of thousands of
Yeah.
dollars per patient. Not only
Hmm.
that, you're saving this thing of the MTP, the massive transfusion protocol. So patient who gets blood in the field, you're probably saving 10, 15 units downstream that they would have needed if they would have gotten the blood much later. Now they're in DIC, and now they're in the ICU. They're ballooned out, and they're much sicker, and they may even die after that. So there's so many downstream benefits here. But like you said, Ed, people have a trouble connecting those dots, and they also are not valuing the role of EMS in those dots in general.
Yeah. And that's one of the bigger problems. But we're going to dive into this paper right on the other side of the break. We'll be right back.
Hey everybody, it's Ed, and I want to tell you about the Monday Afternoon Journal Club. It's a new thing we've been doing on the Overrun here on YouTube, and we're really excited about it. We've gotten a lot of really good feedback for it. What we're doing is we're taking new journal articles that have been published within the past year, 6 months, 3 months, and sometimes even the past couple weeks, and updating you about new EMS information, whether it's clinical care, response times, operations, all of those things. We're bringing you the newest EMS data. So subscribe to the Overrun on YouTube and check out the Monday Afternoon Journal Club most Monday afternoons. Now back to the show.
All right, we're back with Dr. Peter Antevy. Dr. Antevy, this paper came out a month ago. This is brandy new stuff. Tell us about this paper that came out of Florida. Tell us what you've done here with this 1,308 patient cohort that was analyzed by EMS in the field for sepsis.
Yeah, thanks. So this is something Ed and Danny we've been doing for a long time. If you look back at our Palm Beach County Fire Rescue YouTube channel, we have videos that are like 7 years old now. That is when we first rolled this thing out, and it was obvious to us back then. And we knew all along that earlier antibiotics, fluids, and pressors is what these patients need. And so we just rolled it out. Okay. So this is a retrospective sectional chart review. And we didn't look back at all those years because it turns out that in just the past year, so this paper was from June 1st, 2023 to June 30th, 2024, we actually had 1,308 patients who actually got antibiotics for sepsis, right? That's a lot. That's a lot if you think about it. For those people who want to know how big Palm Beach County is, it's about 1 million residents. We have about 1,500 paramedics, 55 ambulances, 2 helicopters. It's the largest county east of the Mississippi, right? And this is really the largest paper to date that looks at this many patients getting antibiotics. Now, I'm going to get to the downsides of the paper, which will be in our follow-up, right? But at the end of the day, there was 2 questions that we asked. This is kind of like just the initial building blocks so we can build this story over time, which is, if you're a paramedic, can you actually have a sepsis protocol, adhere to it so that you're identifying pre-hospital septic patients and you're giving antibiotics? That's number one. And the second thing we looked at is how fast can we give antibiotics from the time the caller made the call? Those are 2 important things. Now, obviously, you would want to know, of those patients who were sepsis alerts, how many of them actually had sepsis when they got to the emergency department? That's coming. And then how many? And we have the data. We just need to publish it. And before I go further, it's because the hospitals didn't want to give us this information, right? In this particular county, we don't have a health data exchange. So we were going a la carte. And finally, we had to get some people involved to basically, and there's laws in Florida forcing them to give us the data. So now, remember, we transport to about a dozen different hospitals. We have to now go to each of those hospitals, give them the list, and have them abstract the data points for us, which they're now doing. And so we have, of the 1,308 patients, we have about half of those patients now done, and we're just clawing the other half back. But let me skip to that later. We can talk about that later.
Sure.
Let's talk about this. Our protocol is very simple, and it's based off of the Q-SOFA score, which I'm sure many people know about. But basically, it looks at, does the patient have a suspected infection? Yes or no, right? And then if they do, we use something called the HAT criteria. It's just a mnemonic to help you get through QSOFA quickly. And so what does that mean? HAT is hypotension. We use 100 as our as our threshold. So below 100, okay, that's a point. Are they altered? That's the A for HAT, altered mental status. If they're altered, that's another point. And then the T is tachypnea, so greater than 22 for adults. And then also in the T, we also added that extra end tidal CO2. This is something that Dr. Chris Hunter out of Orlando published many years ago, showing that if you have an end tidal of less than 25, that's because you're compensating for a metabolic acidosis. So you have a metabolic acidosis from the sepsis, from the lactate, and you're trying to compensate for that. You're trying to push your pH towards 7.4 by breathing off more CO2. So um, it kind of, you have to think through that a little bit to show that an end tidal of less than 25 is a surrogate marker for metabolic acidosis. So hypotension, altered mental status, tachypnea, or a low end tidal, that's it. In someone that you suspect has some sort of infection. Very simple. So first part of the study is, can a paramedic look at a patient and say, yes, I think you're sepsis, and then accurately pick that patient out? That's number one. And then can they provide the protocol? What's our protocol? Our protocol was Rocephin, which is ceftriaxone, 2 grams. And then for broad spectrum coverage, we also added gentamicin intramuscular. Just so you know, I've already changed it at one of my agencies, but we're changing the 2-drug regimen because people don't like 2 things. We're going to go to cefepime, which is a 4th generation cephalosporin. It's broader spectrum. It's what the ED doc is going to give anyway when you get there.
Right.
Probably going to add on Vanco. They're probably going to add on other things too. But we decided now we're going to move to that. But for this study, it was Rocephin Gent. IV Rocephin, IM Gent. And the Gent was 80 milligrams IM. We have a protocol of giving up to 2 liters of saline if time allows. And I can talk about that in a different agency that's actually using the life flow to give fluids quickly, which is incredible. And I think that's really the way to do it. Push dose epi. So we don't have any more epi drip. We don't have Levofed. We have push pressor epi, period. We use a whole lot of it. And then in 2023, of course, once I got all that stuff rolled out and all the people who were upset were not upset anymore, I then rolled it out for pediatrics as well, which had never really been done before. So that's in play.
So
I'll stop there for any. Before
I'm interested in. I mean, I'm interested in all of it, but the push dose epinephrine over, I guess, any other pressor, is that a cost, ease of use, availability kind of thing, or?
Yeah, listen, as many people know, Levofed would probably be better because it doesn't cause that same kind of tachycardia that you would have with epi, but we are a bridge to an infusion, and we're just trying to bump up the blood pressure and just give them a little extra squeeze. And so we chose push pressure epi because that's what we use for pretty much everything else. And this is not a long-term thing. It truly is a bridge. If you look at our transport times, they're not that long. And we're giving, 10 mics, 20 mics, maybe 50 mics over that period of time. So it turns out we're not really giving that much. The pressure is coming up nicely. They get to the emergency department and they get put on something like Levofed there.
Okay.
So Doc, I'm interested too in the protocol. You mentioned saline up to 2 liters. Did you think about lactated ringers, or why saline?
Yeah, so I think both are horrible options, and I'll tell you what we're doing very soon. So yes, so LR is better. We just don't, we're not going to carry both saline and LR. Number one, that's
now. Wait a minute. I'm to understand that if someone is in a shock state, we're not supposed to give them more lactate because it'll increase their lactate. Why would we do something silly like that?
And you're going to confuse them.
Wrong understanding, right? I will tell you that LR is not good for TBI. So, if you end up having these 2 fluids on your vehicle, it turns out it's bad for TBI, both of those. It's bad for sepsis, both of those. Bad for anaphylaxis. You know what is better and actually works really well, that we are already using, but again, because sometimes what we do is so bleeding edge that it pisses people off. We started slowly, but Well, so the answer is plasma. I will say, because we're going to say it here first on the Overrun podcast, that it's 2025 right now. In 2026, some of us will start, and many will hopefully will follow. But plasma will be available to everybody in a crystallized form or in a dehydrated form. It's called spray dried plasma. It'll cost something like $60 to $100. You'll add some fluid to this empty bag that has this crystallized substance in it. You'll shake it up, and you're going to have human plasma, like real human plasma.
Sweet.
And that is going to fix sepsis, because what it does is, and I just gave a whole talk on this, is that it actually fixes the endothelial layer of that blood vessel. Remember, in a shock state, in sepsis, you have leakage. In anaphylaxis, you have leakage. In TBI, you have leakage. It turns out that the plasma is like that Flex Seal, that, like, those commercials where the guy puts the tape on the thing. Plasma acts like Flex Seal, and it's human plasma. So once it comes out and it's available to everybody, and I'm sure people aren't going to do it right away. They're going to wait for the RCT, right? That's going to be coming out in 2080. So we've already rolled out plasma for TBI. There's lots of data on it, and there's actually an RCT that's actually just got launched out of Northwest in Chicago. That I got on the phone with the principal investigator with, and he says, Pete, we're already giving plasma in the neuro ICUs. We already know it works, but the right thing to do is to do an RCT. We just started with it, and we're going to publish our data. But anyway, back to the sepsis thing. I don't think LR is good. I don't think normal saline is good. I think plasma will be the answer.
So I think that the way that you answer that is in, obviously that's why we have you on the show all the time, Peter, because you actually, I like the way that you are able to answer and explain your reasoning behind things. One of the most important things, I think that if someone is not necessarily familiar with data, I think that seeing a study like this, and this isn't an insult to you or anyone else on the team, I think that it's easy to read a paper like this, a retrospective analysis, and what you're looking for is, can paramedics recognize sepsis? I think it's easy to look at that and just kind of be like, yeah, okay, of course we can. Yeah, I know how to do that. But what I want to reinforce is that it's a lot of data is building a preponderance of data, right? It's building up on a foundation and building things up. So you have to start with, yeah, you know what? We can recognize sepsis. We can see this. We can determine it in the field. Then you have to follow it with, not only can we recognize it, we can treat it. And then you find, so that in this process, when they talk about, finding the RCT for plasma or for anything else, it's just the sequence that we have to go through. The problem that we tend to run into is that there aren't a lot of people who are willing to do a lot of studies for myriad reasons, and they range from, financial problems to, laziness.
Well, it's work, Ed. You got to get somebody
busy,
to crunch
busy,
the numbers.
busy schedules.
You got to collect the numbers. You got to write it.
Yeah.
You got to get it peer reviewed. You got to make the submissions. This is a lot of work. I mean, if you do
you
a
have to
paper,
go to each hospital and get individual data.
it takes
Yes,
it takes a year or two. People don't realize you can't do this in a week. This is a year or two of hard work, of data collection, of collating data, of getting somebody to understand the data and being able to put it in a digestible form. It's a lot of work, and a lot of people don't want to do it, but it's exactly what we need to do.
Let me kind of apply a framework here that I think would be important, because I think that there's two types of way that you can collect data. Number one, you have people out there who are like us. We are clinicians. We're on the ground. We're treating patients. At one of my agencies, we see 160,000 patients a year, and so we are on the clinical aspect of it. You go to any medical school today, and you walk into the emergency department, and you're going to find the clinicians, right? You walk upstairs 3 floors where there's nobody walking. There's people who are huddled up in their labs and everything. Those people are as far away from the patients as possible, and those are the researchers. So in medicine, there are like the hardcore researchers who are research heavy, and they're very smart. And then there are the clinicians who kind of do more of the chip shot, retrospective types of things. But all those things link together. So here's how this happens, right? You have people like Sheldon Cheskis, who's I mean, this guy I look up to. He's just one of the smartest people. He's out of Toronto, Canada. And so he's the guy who's doing all of the randomized controlled trials. He's the one who did double sequential, right? He published that paper in November 2022 in New England Journal. He's now doing the pit stop study. He looks out, him and his team look out and they say, I see people out there who are doing these things, and I see a paper pop up here. Like, if you look at the double sequential stuff, the first double sequential case report was in 1995.
Yeah.
That's decades ago.
Yeah.
Then more case reports. Him and his team said, we're seeing all these little case reports, chip shots. We don't know what to believe. The science doesn't believe it yet. We're going to take on that randomized control trial. And like Danny said, it's big. It's a lot of money. It takes a lot of years. So people like me, I hate to say it, I'm not the RCT guy. I'm going to give you this chip shot stuff, which some people will be like, oh, this is fluff, easy to do. It's not so easy to do, to be quite honest, but we're doing it. And it's almost like
if it was easy to do, everyone would do it, and we wouldn't have to have a podcast discussing it.
Right. So and so what we do is we plant the seed, right? So this plasma for TBI thing that we're doing, no one's doing it right now. There's an RCT starting, but once people see what we've done, then the people who are the RCT level people, and there are many of those who work within EMS who are not purely clinical, they will then say, oh, let's go do that and take it to an RCT. That's what Sheldon and his team are doing in Toronto. We published a paper recently, a few months ago, on ketamine for refractory seizure. There's a lot of people out there who'll be like, we need to see an RCT. Well, there are probably people sitting around here somewhere who are hardcore researchers who are going to say, we're going to put that to the test, and they should, right? I'm not telling you shouldn't, but so just so you guys know, that pit stop study that Sheldon Chesky's is doing, they're going to finish data collection by the end of this year. That paper will be published Q1 2026, and it's going to, I think it's a cluster randomized trial. It's going to show, do fluids matter and do antibiotics matter? They're going to have all of the downstream data you guys really want to know. And they're going to want, for example, what's the mortality? How many ventilator days did you have? Did they go to the ICU? All these things that we are actually want to know with even my own data set will be answered with his data sets. That's why I'm telling you that 2025, there's a lot of people doing antibiotics already, right? Because they've kind of heard what we're doing and other people's. But in 2026, the floodgates are going to open and it's going to be game on. And that's why I'm so happy we're doing this podcast today, because everybody out there needs to understand it's coming, whether you like it or not. The question is, whether will you do it once you see the data? Because last thing, and I'll shut up, the double sequential stuff that he showed double neuron intact survival if you give somebody who's in refractory or in recurrent VF double sequential. Double. You go around the country today, very few people are still doing it. So that's my concern, that the data is going to come out, it'll be published, and people are going to be like, I'm not sure what to think anymore. Go ahead.
So I think that's an interesting, and I guess I'm interested in how quickly data moves to practice, because, you know, Danny and I are lucky enough to be in a situation where we get to talk to people like you and, you know, and Dr. Milne and all those people. And I remember when Chesky's put out the original DSED papers, and, you know, it was a lot of like, oh, this is interesting. You know, I'm not really sure about all this. And I feel like now in 2025, it's kind of like, yeah, we do dual sequential defibrillation now. That's what we do. I don't think there's enough, you know, projects or people doing it, but I don't feel like it's a debated topic so much anymore. And what's important about that is that it took 3 years, right? And I say that as like 3 years is a short window from here is what is frankly a novel treatment for a known illness, a known disease. And now it's kind of like, oh yeah, no, it's just a thing that we do.
Well, but I mean, maybe you do, but a lot of people aren't doing it. Now,
right, you know, of course, yeah.
Yeah, but there is an extra variable in here, which is that the vendors that make the defibrillators,
yes,
and one is worse than the other. I mean, one is actually okay. One is still giving people documents that are warning them that if they do double sequential, then and the monitor burns, or that they're going to burn the monitor, which we know is not true. And but they're still putting that out. But I would ask someone who's not doing double sequential, what happened to the last 5 patients who are in refractory or recurrent VF that you brought to the hospital? You know what the answer is? They all died. They all died because there's no one there taking them to the cath lab with the Lucas on. There's no one doing ECMO. at 99.9% of hospitals. So why the hell not throw a second defibrillator on? Really? Are you
Well,
really?
and like you mentioned, if EMS is going to take ownership over cardiac arrest, which is it's what we're supposed to do, that's on a long enough timeline. That's kind of the next thing, right? Where Dan, you and I talked, at least a decade ago about like VV ECMO out in the field, right? Because there was a hot minute where the conversation was like, well, you can theoretically hook up someone to VV ECMO and then essentially work that as a bypass in cardiac arrest. And I'm like, that sounds awesome. And then the conversation turned to like, well, you actually have to cannulate the patients. And it was like, I'm not gonna do any of that.
Well, everybody saw that one picture of Dr. Lamo with Samu doing ECMO in the Louvre, and everyone's like, we should do that. And it was like, but the D
not everyone is going to be in the Louvre.
It was a cool picture.
It was a cool picture. But yeah, it's, and it's funny because you and I worked for a place that 10 years ago, we were doing double sequential, as a matter of course. It was, oh, you go to one shock or two shocks, now go get the other monitor because we're going to do something really weird. And, but we never studied it. We never followed up on it. We never went to the next step. And that's what needs to happen here. And it starts with those retrospective looks. And then you can get to the RCTs. And now you've got a good basis of data. And that's what we need to do in pre-hospital. And we do a journal club every week on this channel. And I'm going to tell you right now, most of the time, we always complain that there's no pre-hospital research. We need pre-hospital research. And anything helps. It's a good thing. Take something you're looking at, take something you do in your agency and go, does it work? Does it not work? How did these people do? Those are simple things. Yes, it's low-hanging fruit, but it's a start. It's a basis. And then you can go from there.
Yeah. And you know what? I mean, I love that. I'll give you one example that people are still resistant into doing, which is epinephrine for cardiac arrest, for the shockable rhythms. Okay. There's plenty of data out there, and I give talks on this, and I put out all the data. Treatment of epinephrine for a shockable rhythm came out in 1968 in JAMA, and the study was done on dogs. Okay. Since then, there have been studies to show that epinephrine in humans, shockable rhythms, makes things worse, and the outcomes are worse. So why is it that we're still using epinephrine in shockable rhythms? So what did we do? We removed it.
But the book says.
Right, that's
the book says.
That's the thing. So like, what? It's very interesting. Why aren't people going and actually asking these tough questions? Why are they just taking everything? And so this goes back to the really big sour point for me in all of this whole thing is that EMS is now a subspecialty in the House of Medicine. We are very different than anything that happens inside the four walls of the hospital, but we're still taking our cues from the AHA and people who are ICU doctors. And so I think we as an industry, as a profession, need to own our side of the house, right? You would not go ask a neurologist how to do an appendectomy, just like you shouldn't go ask an ICU doctor how to treat a 2-year-old at the side of the pool or a 65-year-old on the tennis court who's in refractory VF. No, thank you. We got this. We have our researchers and we can do it ourselves.
I'm 100% going to ask a neurologist how to do an appendectomy now, just because I want to see to do what?
Right.
What
exactly?
What's an appendix? I don't even remember that. But no, I think that that is kind of the bigger overriding point, right? Is EMS started out as sort of I hate to say like an operation of convenience, but people are out there, bring them here. And I think that more than anything else, certainly the whole point of this show is, we're trying to improve the practice and trying to improve the profession. And I think that, and whatever, it might've been 10 or 15 years ago where we got to a point that we tried to integrate ourselves into the hospital system so much that I worry that we almost got to a point of being, and I'm going to use the word subservient, but I mean it in the most academic way, where we got so concerned with fitting in to a niche that we don't belong in, right? That it became like, forcing a puzzle piece into a place where it doesn't work. So now I feel like the profession is in a place where we have a direction we can go in. We being, everybody, we have to choose which way that we go. And I think that in a lot of operations, it's easier to do nothing than it is to do anything, right? So I feel like, like, all right, you know what? I just got to get through today. I don't really care about what happens tomorrow because I got 4 trucks that got to be staffed. I have competencies I have to do. I also have this, I have that. And in that way, it's very difficult to do data or to look over any type of research that you have to do. And I worry that that's why things don't get done. So, when we talk to like, big city projects where they have a lot of money available to them, it's always easy to be like, well, yeah, I've got $6 million in a fund where we can actually do this study. What I wonder, I want to hear, I guess, your response to people who are in smaller operations that want to try and pursue these types of progressive protocols, but might not really know where to start. And then we're going to wrap it up there. I'm going to give you the last word on that.
Yeah, I mean, listen, whether you're a large or a small program, I think that you have to understand the pain points that you have. You have to look at the types of patients that you're seeing, and you really have to, I think, get out there and network. There are lots of agencies out there that don't have the right medical direction. They don't have the best EMS leadership. And without that combination, everybody downstream from there suffers. So, for example, if you came to Florida and you had a choice of small agency number 1 or small agency number 2, but small agency number 1 was actually doing all the things, they were maybe even doing whole blood, finger thoracostomy, ultrasound, and so forth, you're going to recruit and you're going to retain people, right? But on the other side of that coin is the fact that, and I just gave a talk on the future of EMS just the other day when I was in Michigan, which is that if you're a small department, you don't have the funding or the resources, are you going to go buy a $3,000 ultrasound machine? Are you going to pay for whole blood, which is $650 a unit, when no one's paying you back, right? So there are people there who want to do great things. So I would start with the things that don't cost you any money. High performance CPR costs you $0. We should be doing high performance CPR. There are things that again are more costly, but double sequential. You could do double sequential with a monitor, defibrillator, and an AED, right? So you could get that done. And there's videos that Sheldon Cheskis has put up online for people to learn how to do that. The last thing I'll say is, and this is where EMS has to be a little concerned, which is, when was the last time any of you used a Kodak camera? When was the last time any of you drove in a yellow cab, right? So I think that healthcare is moving more away from the hospital into the home. Who's more poised to do in-home medical care than we are, right? Problem is that if we keep seeing ourselves as ambulance drivers, then these big private companies that are backed by venture capitalists and private equity, and they're out there, by the way, they're Ready Responder, it's Ambulance. There are entities out there today that are going to come into our communities, treat people at home with paramedics, right? And we're going to be sitting at the station, at the fire station in my case, waiting for 911 to be called. Why aren't we in EMS going more towards the home and doing things like, community paramedicine is one thing, but actually partnering with other entities to send our paramedics into the house to do care that we get paid for, and that we could actually own the pre-hospital setting in general. So I think that if you're out there and you're just thinking about waiting for the 911 call to happen, or I'm just not going to change my protocol, you're going to be Kodak.
Yeah.
You're going to be the yellow taxi, right? So Skype, right? I mean, wake up, people, right?
No, yeah, I think that's probably one of the best points that can be made in medicine in 2025. And
I love it.
Again, that's that type of stuff. That's first semester business school stuff where the conversation is like, all right, who remembers X product? And we're like, yeah, exactly. Like, remember BlackBerry?
Right.
And it's, you have to adapt to the times. You have to adapt to the medicine. And the other thing that I think is important to remember is that progress isn't a platitude, right? Like, you have to actually do stuff to progress your project. Just saying that you're a progressive project because you have a Lucas device, or, you have a piston driven CPR device on your unit is different than being a progressive system.
That's what I said. That's why I think that data should be more transparent, because I guarantee you, if you look at the CARES a summary, the annual report from 2023, because that's the last annual report that's available on their website. It shows you about 50 different cities, and it shows you the survival from those 50 different cities. If you look all the way to the left, there's a city that has a 2.4% survival. If you look all the way to the right, you have a city that has a 14% survival. What's missing on the x-axis? They don't label the cities. Wouldn't it be nice? Now they have a graph for the states. So like Vermont in this graphic was the worst, if I'm remembering correctly, and Washington State had the highest. Right? If that data was transparent and your small EMS system, your large EMS system, if that was public, you bet all of a sudden the city commissioners would care, your local community would care, everybody would care, and they would say, hey, Pete, how come your system is so bad? How come you're not doing those things? Data transparency will fix a lot of these problems, but nobody wants to make the data transparent. Nobody wants to do it because it's going to cost them a lot of money.
Money runs everything. Yep.
Exactly.
Well, Danny, you can appreciate, certainly we've all heard that cash rules everything around me. So, but that
Wu-Tang is for the children.
Wu-Tang is for the children. But I do think that those are all like really important points. And again, you know, Peter, we can sit and talk for hours about all this stuff, but for anyone that's listening, go to your administrators, talk about this sepsis protocol. One of the things that we try and do a lot in EMS is we talk about things that can make a difference, that can save lives, that can improve clinical outcomes. Improving sepsis protocol is very easily one of them. Thank you so much for listening to this episode. Thank you again to Dr. Antevy. Check us out on all the stuff we do, YouTube, EMS One, Spotify. We have Monday Afternoon Journal. It's
a lot
on the YouTube.
It's a lot.
It's a lot. Also download the podcast, because if you're watching this on YouTube, there's also an audio version that you can listen to wherever you get your podcast. But for the Overrun, I'm Ed Bowder.
Yeah, I'm Dan Schwester.
And we will talk to you all next time.